So hopefully you had the opportunity to grab your lunch for those of you on the East Coast. And we are just going to talk a little bit for the first 5 minutes on what's going on with our healthcare reform and kind of the resurgence of the healthcare bill that was kind of defunct, I guess, a week ago Friday. So the games are back on, and on Monday, House Republicans met with the Freedom Caucus, some Republicans that had stopped the previous vote on the Trump revision or replacement of Obamacare. Interestingly, it looks like, Tuesday morning, Paul Ryan came out and said that they're making modifications to the bill. And I think, from my perspective, there are some things in the bill that have kind of stopped Republicans' support because they have to get reelected. And I think most Republicans that are up for reelection are very concerned about the CBO's estimate 7 million Americans would lose coverage. And I think the biggest game changer in that particular part of the legislation is the repeal of the subsidies. So right now, when somebody goes out onto the state exchanges, they're getting a subsidy at the point of choosing their health care. So I'll give you an example. I have a friend who's a single mother with a child, and she goes out to the Pennsylvania State Insurance Exchange and purchases insurance for her and her son. And the plan that she is on is a very high deductible plan that costs about $800 a month. And with the subsidies, she's paying about $100 a month. So that's affordable to her. And about 60% of people that are getting health insurance through the exchanges are getting one of those subsidies. So in the Trump proposed legislation, those subsidies would go away and they would be replaced with a tax credit, which is age-based and not income-based, which I think is a big flaw in the system. And they still haven't figured out how they're going to distribute that tax credit. Because to be honest with you, if you say to somebody like my girlfriend who's getting her coverage through the state exchange, you have to wait until April 15th of next year before you get the credit for the $700 difference, she's going to drop her coverage because she can't afford an $800 a month plan. So I think it's simple to see why some Republicans weren't in support of the bill. They are also talking about in the revised or the revisions, one of the things that's been leaked is the Republicans' request for more state authority and less federal government authority in running the state exchanges. So it's going to be interesting to see if you look at the 22 million people that are getting insurance through the exchanges today, about 11 million of them are individuals buying insurance. And then the delta is people that are qualified for Medicaid with the expansion of Medicaid in the states under Obama. And those are all things that may change. I think, in talking with, a lot of people, I was at the Washington Business Group on Health last week in Washington, D.C., and we had participation in sessions with the Department of Treasury on the taxability of benefits, healthcare benefits. And I will tell you their views on healthcare benefits and the taxation of benefits is vastly different from those of us managing benefits. The representative from the Department of Treasury basically said because healthcare benefits are tax-free to the employer or tax deductible to the employer, they feel that they're spending more money on healthcare than putting that dollar someplace else, meaning in wages or some other place, which you and I both know is ridiculous because that's not why we're spending so much on healthcare for sure. It's outpacing inflation, general inflation, and it's certainly outpacing wages. So we'll see what the construct or the deconstruction of Obamacare looks like. I think Republicans are very concerned about their reelection. And, it really is going to be interesting to see whether they miss the mark or whether they hit the target and they can keep, the 11 million Americans that are covered today in a plan that's affordable to them and something that they can sustain. And we'll see how the new bill, which has not been rolled out, and they're still, I guess, in negotiations with kind of reconstructing the bill that didn't get to the floor 2 weeks ago, to see if they can bring it back for a vote, if they can get the Freedom Caucus and some of the Republicans to support the new strategy. It's going to be interesting. I think one of the things that before we move into the pharmacy piece, one of the things that I've heard from a lot of employers, and certainly mid-market employers, I think, are taking the brunt of it. But how do we keep planning, and how do we keep moving forward with our strategy when we don't know what the lay of the land is going to look like? And I think with either a total replacement, or if Obamacare does stay in place today as it is the law of the land, we still have to be doing the things that we do, right? So we still have to be managing benefits. We still have to be really cognizant of our cost and what's driving our cost. So as we move into pharmacy right now, what we're going to talk about is what are the things that we should be doing in the first quarter of this year. So we're going to just spend the next 15 minutes on key thoughts, key pieces of information on what's going on in the pharmacy area. And Kelly will tell you, we're going to be sending notices out. We're going to do these the first Wednesday of every month to just kind of give you a quick little snippet of what's going on and the key things that are changing and the key things that you need to be aware of as you plan for your open enrollment later, if you're a calendar year like most employers are. Moving through the first quarter, I'm going to be talking specifically about what you should be doing and thinking about now to prepare for open enrollment in October, November timeframe. So prescription drugs is still a key problem that we're trying to solve for as employers. You're going to see in the next couple of minutes how big a problem it is and how it's growing. But in the last 3 years, we've had a 10% growth in specialty. That's going to keep growing. If you look at your total annual spend, now we're spending out of the $10,000 to $11,000 per year that you spend on healthcare benefits for your employees, over $1,000 of it is going towards drug spend, and that's going to increase. CVS is projecting that 50% of all drug spend by next year is going to be in the specialty area. The two things that are driving our specialty costs are oncology and inflammatory drugs. So those are the two specialty categories. And then the third one is MS, multiple sclerosis medicines. So we're going to be talking a little bit about in the next couple of minutes, what people are thinking about and trying to control these. But cancer drugs are definitely on the rise. We're going to talk a little bit about what the key pieces of information are that you should be asking in the next, quarter, in the next, couple of months as you plan for building your strategy for what you're going to do for open enrollment this year. Certainly hepatitis C, PCSK9 is that cholesterol managing drug that's $1,000 a month versus the name brand drug on the market, Lipitor, which is $100 a month. So how we can control the utilization of that and so forth. And then really just how you can monitor those orphan drugs, looking at your utilization. So an orphan drug, and there's been more and more of these out on the market. The orphan drugs are very unique drugs. They're one-of-a-kind drugs that are targeting a rare or unusual illness. And we're seeing more and more of those in our utilization data. And it's concerning because it's the only drug targeted for that particular disease with efficacy, being effective. And that is concerning us because we really need to make sure that we are in front of looking at different ways to manage our costs on those because they're just so expensive. And of course, we're just grappling with the whole pharmacy issue and trying to keep them under control. So this is a key slide for me. And I promise to make this fun. this is really not a fun slide. So this is an important slide, and we're going to post these slides, but if you print any slide out, I would print this one out, because this really encapsulates, our concern and our problem right now. So if you look at prescription drugs, they're making up 26% of our total healthcare spend. So with medical included, 26% of our total, $10,000 to $11,000 a year spend per employee is spent on pharmaceuticals. And if you look at the traditional drugs, so those are the basic non-specialty drugs, 61% are going through your pharmacy benefit, but we still have 47% going through your medical plan, which is a problem, because if they're going through your medical plan, they're probably name brand drugs, and you're not getting a rebate and you're not getting a discount on those. So that's very concerning. And then if you look into the specialty drugs, it's a very, very small percent of people on specialty, but it's going to be 50% of your total spend by next year out of the pharmacy spend. And 53% of those specialty drugs are going through your medical plan. So those are typically the oncology drugs that are injectable, that are being delivered in the doctor's office. So right underneath that, you can see we have hospitalization is a site of care where people are getting, prescription medication through the medical plan instead of the pharmacy. And then the physician's office is another site of care where people are getting their drugs, their pharmaceuticals dispensed directly at the doctor's office, which again is running through your medical plan, not your pharmacy plan. And then that last little bit is infusion and home care providers. So what we want to be looking at, this is the first quarter of the year. You want to be looking at your calendar year end information, your utilization information for 2016, and trying to figure out where you fall. So this is a key opportunity for you to be looking at this right now and saying, what are the drugs that are running through the medical plan, and how can I push from the left to the right? Right? So we want to push the drugs being administered in the hospital or outpatient setting in a hospital, in the physician's offices. If there's any we can move to home care, if you move your spectrum from left to right, you're going to be saving, you can save hundreds of thousands of dollars a year. So those are some of the things that we're looking at right now. The pharmacy coverages that are going through the medical plan are easy to pick out of your utilization. So what you want to do is you want to ask your carrier under the medical plan for your J codes. So they're coded under the J. J is the first letter on those diagnostic codes that you get. So they can pull them out, and they can actually tell you, out of your pharmacy spend, here's how much is out of the pharmacy that's running through the medical and the pharmacy. Here's how much of your utilization running through the medical plan. And then you can even dive a little bit further and see where they're being dispensed. Is it in the hospital outpatient? Is it in the physician's office? And is there room to put some clinical programs in there to modify how people are using the site of care? And this slide, you can take a look at this later. I'm not going to cover it in detail, but you can see how different the cost is. So if you're looking at, let's just say the cancer drug, in the doctor's office, it's $13,000. In the patient's home, you can see, depending on who's administering it, it's a little bit more expensive, but the hospital setting is just astronomically expensive in the outpatient centers. So if you look at, this is an actual, these are real costs. These are average data. This was a Cigna survey. It's very interesting to see how taking a look at where those drugs are dispensed can really make a huge difference in your cost. So we're going to jump right through to what's driving cost. And we're going to talk a little bit about the things that you can be and should be looking at. It's really interesting to me that if you look at what your top drugs are, right? So if you get your calendar end data for 2016, and today you should be getting that data, and really sitting down with your carriers and your consultants to kind of go through okay, what's driving our costs? What are our top utilized drugs? Are there clinical programs that we can put in place? And I will tell you, some of the exciting things that I heard last week from the Fortune 50 is they are doing a lot of risk-based pricing within their pharmacy programs and the value-based purchasing. And an example of that is, the hepatitis C. A lot of the larger PBMs, the larger pharmacy benefits managers, are basically saying they're at risk for some of that. So if you have somebody start on a hepatitis C drug, which is approximately $80,000 to $85,000 per member per treatment, they're basically saying if somebody stops the treatment in the middle of the treatment program and then has to start over again, they're at risk for that. So they're going to eat that new charge and they're not going to charge you again. And that's because we're putting them solely responsible for adherence. They should have that specialty drug PBM purchasing arm calling people to make sure that the medication that they're taking can be tolerated. They have the proper handling instructions. Some of these specialty drugs require refrigeration. They require special handling, and dispensing, and just really checking in with the member. There's one particular specialty drug that has flu-like symptoms for the first 5 days. So one of the things that you can take a look at to see if you have that currently in your plan is that split first refill. I'm a huge fan of that because if a drug is $1,000 a month, it would be better if you know that there's difficulty in adherence to give the member a 15-day supply for $500 to make sure that they can get through those first couple of days where they have the flu-like symptoms or the severe reactions, to see if they can maintain that and keep taking the drug before you give them the full dosage at the $1,000. There's a new MS drug that's out on the market that's giving us a lot of concern, just in that, the adherence rate is 40% dropout. So we want to look at those split refills as an opportunity. And really, this is just a refresher of what's driving the cost. It is adherence, it's cancer, and it's the new treatments. And one of the things that I will tell you is if you look at the top runners on the drugs, it's inflammation is number one, inflammatory conditions, cancer's number two, and MS is number three. And the one thing that I will tell you, if you look at that little circle in the middle, the immunoglobulin category, there's a ton of trials going on for new drugs. And I've seen a lot of stop-loss contracts lately that concern me because they've basically excluded coverage, stop-loss coverage, for clinical stage 3 trial drugs. And there's a lot in that category, and they're very expensive. So watch your stop-loss contracts and make sure that there's no added clauses specifically to stage 3 trial drugs not being covered under the stop loss, because those can be hundreds of thousands of dollars. And then finally, we're going to kind of just move into, what are the key things that we talked about today that you should be looking at in the quarters. So if you look at the little square that is up in front of you now, these kind of are just by quarter. So if you look at what you need to accomplish by quarter in order to get where you need to be for open enrollment and your strategy on your plan design, right now in the first quarter, you should be doing the utilization management and a retrospective and a prospective review of your utilization to see what clinical programs are called for to control your trend. And then obviously the site of care we talked about, and looking at, adherence, the site of care, and what new drugs are coming out on the market that may affect what your diagnosis or your clinical disease categories are that are running in your program. And obviously the channel management, we've talked about that. And the formulary management is just so important to take a look at what's driving your cost and see what clinical programs and what you can do to make sure that you're managing your trend. And then this kind of just wraps it up. I like this one slide because I mean it really is it's kind of a chain, and there's spokes in the wheel, and with if one of these is not turning properly, you're not going to get where you need to be. So this is kind of, my attempt to kind of show you all of the different pieces that go into managing your pharmacy benefits, that are critical. And you really have to start now. You can't wait until later on in the year. Because if you do want to change some of your clinical programs, I mean, we have some clients that are talking about putting in a very strong step therapy program for certain categories of drugs that are their top drivers, and saying to members, before you go on the most expensive drug, you have to try the less expensive drug first. And that does require communication, right? So if you're going to change the way that your employees are using their pharmacy plan, and potentially telling them that a drug is either not covered now or going to be much more expensive, you have to get far enough out in front of that change so that you're communicating with the member to give them enough time to go to the doctor, have the clinical discussion, get the new prescription, and get that in place, obviously, before their open enrollment, before their renewal into the new year. So, Kelly, that kind of wraps it up. I know it was quick, but I wanted to give you kind of a snippet of what's going on in the marketplace. I think we could have probably talked for an hour on politics and healthcare reform. It's one of my favorite topics, and certainly changing rapidly. Every morning I scan the news first thing and see what happened, and I'm never disappointed. It's definitely constantly changing, and definitely have to make sure that we're all aware of what's going on. And for everybody, that hasn't attended yet one of the conferences, we look forward to seeing you in Baltimore in a week and a half, and certainly in Chicago, one of my favorite cities, in June. And then we have Austin, Texas coming up in September. So I look forward to seeing everybody at the conferences.
Thank you so much, Marybeth. I know you could have talked for an hour, but I think this was perfect. And I hope everyone will stay tuned. We will send out links for registration for next month's Power Lunch, when maybe you can talk all about what's going on in Washington, Marybeth, and what the Republicans have brought to the table or possibly gotten passed at that point. Who knows? Wednesday, May 3rd at noon. We will do this again.
Yes, looking forward to it. Thanks, everybody.
Thanks, Marybeth. Have a great afternoon.